It is my pleasure and honor to participate in this prestigious Congress of the Egyptian Society of Nephrology and Transplantation Chapter. And before I'm going to discuss the challenge of the use of checkpoint blockade in kidney transplantation, I would like just to say that we missed Professor Maher Fouad. But we hope that Professor Ayman Rifai will continue the success of this well-established chapter by Professor Maher Fouad. I'm going to discuss checkpoint blockade under the following sectors: introduction, followed by different numbers of checkpoint inhibitors, the adverse effects, because we need to know the tolerability, the using of these molecules in treating autoimmune diseases, cancer in autoimmune disease and transplantation, the future of immunotherapy, and then the final message before ending the presentation. Cancer and transplantation is always a critical and essential subject. This is why through the last year we have two presentations from the President of Society, Professor Hani Hafiz, and the Secretary General of the Society, Professor Ayman Rifai, speaking about the aspects of post-transplant malignancy. Now, we have this very interesting data from the United States. They have nice registries for cancer. So 7 million patients with cancer compared to 11,000 patients with cancer, but with prior transplantation. The key message from the data registry: irrespective to the type of cancer the patient may have, the presence of prior transplantation, as you see here, this is the death rate per 1,000 patients per year, in comparison to those who had prior transplantation. As you see, mortality is higher if transplantation is there. And this is adjusted hazards and by different models. So irrespective to the type of cancer, always adjusted hazards of mortality and cancer specific mortality increased in comparison to those who had no transplantation in all the types of cancer. Just to show you the challenge of using this immunotherapy in treating cancer with transplantation, I'll start with this case. A 74-year-old male transplant patient who developed lung cancer, non-small cell lung cancer, treated with this drug, which is FDA approved, and it is one of the members of checkpoint blockade agents, Opdivo. And what happened? Acute allograft failure, creatinine increase from 0.7 milligram per deciliter to 7.5 milligram per deciliter. And the biopsy confirmed bad rejection. As you see, edemas, interstitial edema, interstitial hemorrhage, tubular injury and tubulitis, vasculitis, and C4D deposition. So this is the challenge. We use immune checkpoint inhibitor blockade that will stimulate immunity with subsequent rejection. So let us to review checkpoint inhibitors. This is a model of antigen presenting cell, dendritic cell. The dendritic cell has many molecules, usually ligands, on the surface, either to this side or this side. All these are ligands expressed on the dendritic cell. If the ligand binds to its receptor on the lymphocyte, suppose that this is one example, it is BD ligand 1. When it binds to its receptor BD1 on the lymphocyte will be inhibited. And then cancer will flourish, and this is what happened in cancer. This is why we would like to block the pathways of inhibitory ligands or inhibitory receptors on the lymphocytes. So when we think of immunotherapy for cancer, we would like to stimulate lymphocytes. So all these are checkpoints, either inhibitory and stimulatory, and you work now on the inhibitory pathways to stimulate lymphocyte from exhaustion. Again, this is the lymphocytes, including inhibitory receptors. If these receptors bind to their ligand on the antigen present cell, the T cell becomes exhausted and inhibited. While if the immune stimulant receptors bind to ligands on the antigen-presenting cell, T cell is activated. So the rationale of using immune checkpoint blockade is to stimulate lymphocytes for the sake of combating tumor. And this is why it is very exciting, and this is why the Nobel Prize in Physiology or Medicine came in 2018 to these professors co-shared the prize, Professor Allison and Professor Honjo, for their discovery of cancer therapy by inhibition of negative immune regulation. The concept of immune therapy and checkpoint inhibitors is expanding. These are model of the two textbooks speaking about this topic. Again, so we have receptors on T lymphocytes, inhibitory receptors, and their action will be evident when they bind to ligands on the antigen-presenting cells. So if we want to inhibit this inhibitory pathway to stimulate lymphocyte, we have drugs, either anti-CTLA4, ipilimumab, or tirimilimumab. We have antibodies against the PD-1 program, this one, nivolumab, and other molecules here. And we have here BD ligand 1 inhibitors, so atezolizumab, which blocks BDL1, and when BDL1 is blocked, it will not bind PD-1, so the cascade will be inhibited. Inhibiting inhibitory pathway will stimulate lymphocytes. And we have other molecules. The studies and the trials are growing to test for these agents against LAG3, TIM3, this molecule CD40 ligand. So a lot CD40 receptor. A lot of molecules are being tested nowadays. FDA approved some of them. So this ipilimumab, nivolumab, Pembrolizumab, atezolizumab, avelumab, and durvalumab, all these drugs are FDA approved for treating a specific cancer, as you see in this slide. So this is the drug. This is a target pathway, either CTLA4, PD-1, BD ligand 1, and this is the cancer type for which FDA approved the molecule for treating this cancer. Is there any trials documenting the efficacy of immune checkpoint inhibitors in treating cancer? Yes, this is one of the trial, CheckMate 214 trial, that tested the use of combined nivolumab plus ipilimumab in comparison to sunitinib for treating advanced renal cell carcinoma. And the study was positive, showing that the use of combined immune checkpoint inhibitors was associated with better outcome in comparison to sunitinib, to the extent that the authors may consider this combination as the first-line treatment. Another study for treating advanced or metastasizing non-small cell lung cancer, Keynote 042, this is a randomized open-label controlled phase 3 study, documented the superiority of the Pembrolizumab to chemotherapy, and so overall survival is significantly superior to the chemotherapy, and so the way is paved toward using immunotherapy in treating cancer. A lot of publications and a lot of trials are there. This is a very interesting cancer, Lynch syndrome, multiple cancer in the same patient because of the defect in mismatch repair. You may find gastrointestinal cancers, lymph nodes, and liver activity. And this is PET scan. And after treating this patient with this immune checkpoint inhibitor, Pembrolizumab, as you see, this agent was effective in reducing, and here this is a PET scan after 16 months, showing the great difference in the activity between the basal one and after 16 months of given drugs. Be aware, because sometimes the tumors are not responsive to the immune checkpoint inhibitors. These are called tumors, and they are checkpoint resistant. Because of this, microenvironment, and this is chemokines are associated with hot inflamed tumors, and here we predict the response for the agent. How many clinical trials are there? This is according to this reference, more than 1,000 clinical trials are evaluating immune checkpoint inhibitors targeting this pathway, PD-1, PD-ligand-1 axis in cancer, a very hot issue in cancer. Another point, which is not immune checkpoint, but ionic checkpoint, here the rationale is, with the presence of endogenous necrosis within the cancer, potassium is released, taken by lymphocyte. If it accumulates within lymphocytes, lymphocyte becomes exhausted. So the rationale is to stimulate efflux of potassium from potassium channel, and stimulating the efflux of potassium will keep potassium in a normal concentration inside the cell, and this will stimulate lymphocyte to control cancer. If we think in the opposite direction, we can block potassium channel to keep potassium higher intracellular, and this can be beneficial for graft acceptance and treating organ transplantation. And this is one of the drugs, dalazatide, which was used in this phase 1b trial to treat psoriasis, and it was promising. The third point in the checkpoints is antibody checkpoints. Here we have innate immunity. Here we have Fc gamma receptors, and a lot of Fc gamma receptors are there. If you look here, this is activating receptors to activate innate immunity with subsequent activation of adaptive immunity, and this is inhibitory. So we can play with immune checkpoint, ionic checkpoint, or antibody checkpoints if we want to deal with these points. Let us go back to immune checkpoint inhibitors, because I'm going to focus on the tolerability and adverse effects related to the use of immune checkpoint inhibitors. I think this figure is very smart because it shows if you use immune checkpoint inhibitor, be careful, because you may find side effects everywhere. No organ is exempted from side effect. Skin, here the endocrine system, lung, heart, kidneys, intestine, etc. I like this chapter because it summarizes in a perfect way the toxicities of immune checkpoint inhibitors, and the toxicity is divided into, according to the severity, into 5 grades: grade 1 mild, grade 2 moderate, grade 3 severe, life-threatening, and grade 5 means death. And if we apply grading on hepatitis, we find a little bit higher levels of bilirubin, and here bilirubin above 10 fold, and here above 20 fold, so, and here death. This is very interesting because after the use of immune checkpoint inhibitors, the patient may present with pneumonitis, and the problem is pneumonitis may be recurrent, either because of provocation, if we resume immune checkpoint inhibitors, or sometimes without resuming immune checkpoint inhibitors, pneumonitis can be there and recurrent. The lesson is, if pneumonitis is recurrent, when we treat pneumonitis, it's better to continue follow-up and to give time for steroid and to avoid abrupt withdrawal of steroids. This is a nice cohort of patients, 370 patients treated with immune checkpoint inhibitors. 41 have diarrhea, and 5 of them, the biopsy of the colon revealed the same cytomegalovirus infection. These drugs may be associated with problems in the heart and the cardiotoxicity. Here, this is the name of immune checkpoint inhibitors, and this is the summary of the report of incidence of adverse drug-related events related to the cardiology, myocarditis, pericardial disease, conduction and abnormalities, and stress cardiomyopathy. And here, this is the myocarditis. The presentation can be challenging, can present with heart failure, pulmonary edema, cardiogenic shock, multi-organ failure, ventricular arrhythmias. And here, the treatment depends upon the severity. So the first step and the treatment is based on these 3 concomitant treatments: stopping immune checkpoint inhibitors, using immune suppressive drugs, methylprednisolone pulses. We may even use Antithymocyte globulin, infliximab, IVIG, all immune suppressive armamentarium to face the immune stimulation syndrome. And in the same moment, we use anti-heart failure as recommended by the American Cardiology Society. Renal side effects, yes, these drugs may affect the kidney. And here, this is the grading, just rise of creatinine up to death. And in this grade 1, we just monitor and avoid concomitant dehydration or other nephrotoxic drug and continue immune checkpoint inhibitor. In the advanced stages of side effects, we should stop the immune checkpoint inhibitors and giving immune suppressive to the patient. These are two cases of interstitial nephritis after the use of these immune checkpoint inhibitors. All the time, the use of cascade of immune suppressives to treat these drugs side effects include armamentarium, big armamentarium, as you see, anti-interleukin 1, anti-interleukin 6, IVIG, anti-CD20, anti-interleukin 17, anti-NF-alpha, anti-integrin, anti-interleukin 23, and genus kinase inhibitors. So all these molecules can be used. And this is just in the cartoon, you'll find the site of action of different armamentarium, and we may use non-specific, non-selective immunosuppression like azathioprine, mycophenolate mofetil, intravenous immunoglobulin, methotrexate, cyclophosphamide, thalidomide, or plasmapheresis to work in general. But this is a specific molecules here, for example, TNF-alpha, infliximab, and others, interleukin 1, as you see, anacnira, and here Tocilizumab, anti-interleukin 6. So please stop this slide and look at the different armamentarium. And the wise approach within this article is to go in a stepwise manner. So we start to ask ourselves about this algorithm, and we can proceed for the first line, second line treatment, third line treatment, and fourth line treatment, as you see within this algorithm. Tocilizumab, which is anti-interleukin 6, can be used for treating the side effects and the management of immune-mediated adverse events after PD-1 blockade. However, we need further studies to be sure from its efficacy and safety. Another very, very interesting, and it is considered conundrum, how to use immune stimulation and the cancer grows. And this is hyperprogressive disease. This is quite amazing. And according to tumor growth kinetic, tumor growth rate, the time to treatment failure, we have here, for example, 20%. So we should think of this issue, but we should be careful about pseudoprogression, because after using immune stimulation, there is inflammation. Inflammation is the battle associated with edema, but at the end, we'll find necrosis of the cancer. However, with hyperprogression, true hyperprogression, there is an increase in tumor cells, rapid progression. So I think we should look at the literatures and the science, advancement of science, to know who will take the benefit and who will be resistant for these drugs. Using of these drugs to treat cancer for a patient with pre-existing autoimmune disease or after transplantation, quite challenging. This is a cohort of patients, 751, treated because of cancer by the immune checkpoint inhibitors. 85 of them had already pre-existing autoimmune disease. And the key message is the presence of autoimmune disease is associated with higher incidence of side effects, of immune-related side effects. We should put it in mind when we treat a patient from cancer while he has pre-existing autoimmune disease. Just to be careful. Regarding the issue of transplantation, we would like the graft to continue without rejection, and in the same moment to avoid cancer or to treat cancer efficiently. So we should weigh the balance between rejection and the cancer treatment, because this is one of the real cases after graft nephrectomy due to the severe rejection after using immune checkpoint inhibitor. The graft biopsy revealed cortical infarct, as you see, and some chronic vasculopathy. This table summarizes the data of 7 patients, their gender, time from transplantation to the use of checkpoint inhibitors in years, the type of malignancy, checkpoint inhibitor and the agents, and the number of doses, as you see here. Immune suppression while on checkpoint inhibitors. And this is the when they started the use of checkpoint inhibitor, the patient was maintained on these drugs, and this is the occurrence of rejection or not, response to the cancer or not. So this patient has no rejection but has no response. This patient has no rejection but responded well to the cancer. This is a nice case. It is a bad skin cancer, Merkel cell cancer, that was treated efficiently by nivolumab in a renal transplant patient with preservation of graft function. So you can find here creatinine, urine protein creatinine, and estimated GFR. Everything is fine up to 1 year after the use of nivolumab. It's another protocol showing that the PD-1 inhibitor nivolumab can be used to treat microsatellite stable metastatic adenocarcinoma of the duodenum by following this protocol. 1 week before, increasing the dose of prednisone to 40 milligram per day. Then the dose with concurrent treatment like this, 20 milligram, targeting sirolimus with targeting this level. 1 week after, prednisone is 20 milligram. From 2 weeks to 6 months after the use of checkpoint inhibitors, prednisone 10 milligram per day, sirolimus targeting 10 to 12 nanogram per ml. After 6 months, gradual tapering to 5 milligram prednisone, sirolimus continued to maintain a level 10 to 12 nanogram per ml. And the authors of this case claimed that if the protocol is used, we can use PD-1 blockade safely. Another report for 6 cases of melanomas, they were treated with ipilimumab, and here you can find if the time between the last change in immune suppression and the first ipilimumab injection per month. And although the response was not striking in these 6 cases, but this is some ideas to treat cancer in transplant patients. This is another report about the 20 cases. This is the tumor, melanoma, non-small cell lung cancer. This is the type of tumors. Then type of response. Here rejection 3 cases, tolerance in 5 cases, and here kidney transplant, kidney, cornea, and heart, kidney, liver transplant, and at the end of the day, this is the agent used, and the rejection rate ranges between here 0%, but be aware it's just one case, up to 100%. Again, few case reports. This is the allograft, kidney, liver, heart, cornea. So the total is 20. Rejection here for in the kidney, 8 out of 13, 61% rejection rate. In liver, 2 rejection out of 4, 50%. In the heart, 1 rejection and 1 tolerance, 50% rejection. Cornea rejected, and this is the total rate, 60% rejection. Liver is important, and there is a great difference between renal transplant and liver transplant. So this is a report of 14 cases of using immune checkpoint inhibitors after liver transplantation. Here, be aware because 3 patients had lethal outcome because of using immune checkpoint inhibitors. And this is one of the cases that developed severe liver cell failure after using nivolumab. And so we should be cautious in liver transplantation. Regarding the largest reports harvest, I think this is one of the interesting reports because it includes data about 48 patients. All of them were transplant recipients and treated with immune checkpoint inhibitors. 29 cases after kidney transplantation, 19 after liver transplantation. This is the tumor type: melanomas, non-small cell lung cancer, hepatocellular carcinoma, liver transplant and kidney transplant. They use the different agents in the immunotherapy, nivolumab and others. You can just fix this table. The organ transplant outcome and tumor response outcome, both points are very important. So here we have organ preservation, organ rejection with organ failure, organ rejection without organ failure. So here, if we look at organ rejection with organ failure, it is here 5 cases in liver. It is quite problematic in kidney transplantation as well. Anti-tumor response, we may have complete response, partial response, or stability of the disease. So this is the outcome. And this table summarizes the immune suppression during the use of checkpoint inhibitors, the type of malignancy, and the outcome. So please go to this report. And the key messages from this report is disease control rate for advanced cancer patients with renal or liver transplant is 35%, 21% for liver, and 45% for kidney transplant patients. And the ideal response occurs in 21% of all patients. This is another issue. When we transplant, when we have allogenic bone marrow transplantation, and we with the use of immune checkpoint inhibitors either before or after allogenic bone marrow transplantation, be careful of graft versus host disease as shown from this report. I think the future of immune suppression will witness major advances in understanding the response from the genetic makeup, either assessing T cells through the intratumoral infiltrates, enhance the effector function, increase the colonality, greater stemness. All these points will be reduced exhaustion. All these points will help for the tumor response. Tumor cell itself, antigens, increase the tumor mutation burden, immunogenic alterations. So we should look at these points. Tumor cell resistance mechanism to be reduced, and the microenvironment. I think the future will carry a lot of data, and we are hoping to have a magic biomarkers. All these are trials testing the issue of genomic markers. Even epigenetics, with that plays with BDL ligand 1 gene transcription, and as you see here, a lot of microRNA are inhibitory for this BDL ligand. It affects the immune therapy, and here this is the tumor cell, and this is how the epigenetic pathways interact with the cancer treatment. Even HLA typing, if we know special alleles, for example, this alleles is associated with less patients without immunotherapy-related adverse effects pruritus here. So this means that this allele has higher side effect because this is the proportion of patients without the side effects. So even knowing HLA typing may help us to predict the response. How to improve the response? I think I just want 2 minutes. So to know the T cell, tumor mutational burden, to play with the gut microbiome, because there is a hot research about the use of probiotic tablet to enhance checkpoint inhibitors, using anti-CD40 plus immune checkpoint inhibitor to enhance the response of cancer, dealing with microenvironment, or even doing innovations in the molecules like M7-824 by the Merck and GSK, they announced global alliance to jointly develop and commercialize this molecule. So this novel immunotherapy include a trap for TGF-beta and anti-PD-L1 moiety. By trapping TGF-beta and PD-L1 moiety, this will be associated with higher. This is expected to offer a higher response. So M7-824, to the extent that the companies are expecting payment of 300 million euro, and is eligible for potential development milestones payments of up to 500 million euro, triggered by data from this treatment for lung cancer program, plus future approval and commercial milestones of up to 3.7 billion euro. So a lot of money and a lot of investment to treat cancer. The world of immuno-oncology is expanding, and this is a conference that will be held in Spain, entitled Immuno-Oncology 2019 to address all the aspects of immunotherapy and the future of this class of treatment. The question now, to do or not to do, to use or not to use these agents to treat cancer, especially in renal transplantation, I think we are waiting further studies. And up to this moment, the wise approach and the wisdom of discussing the case with experts, I'm proud this is the team of Mansoura Nephrology with Professor Ghunaim, and all professors through this team will learn it, how to discuss cases with the team and how to discuss with others, and at the end we share with the patient. And I think the calculating the risk and the benefits, this is what we have now, and in the future will carry new informations about how to deal with the patient with cancer. Another issue is to enhance education, because a doctor is a student till his death. Once he fails to be a student, he dies. And I think Professor Ayman Rifai take the responsibility. It's a hard job, hard task to accomplish the success of this chapter. And I think this is for the advanced directives of Professor Maher Fouad and Professor Ayman Rifai with the society board and with all nephrologists in Egypt. I think if we work together, I think success will be at the end. Thank you very much for your attention, and I'll be happy if you have any questions.